Thank you, and thank you for the honor of coming to the podium today. Wow, those lights are bright. Um, Here are my disclosures. Really appreciate you guys giving me the same topic that the main speaker for the conference gave today, but I'll do it in 10 minutes. Uh, so we all know that the as far as obesity is concerned, that we have a homeostatic process. In times of plenty, we have weight gain, and when energy stores are low, we have to seek food, and that creates appetite. We also know that metabolic surgery disrupts this homeostatic process. So we didn't know how this worked, and in the beginning times, in the 60s and 70s, as we were kind of learning how bariatric surgery worked, there were a bunch of theories how our surgery actually impacted the physiology of our body chemistries. In the beginning, with the surgery such as the jejunal ileal bypass, we determined that this concept of malabsorption. We knew that the GI bypass interfered with cholesterol absorption. Patients lost a lot of body weight, but they also had really bad diarrhea. They began to have liver failure, protein malabsorption, vitamin deficiencies. That's probably why the GI bypass kind of flew by the wayside. We also know that with the early stages of gastric bypasses like those by Mason and Ito in the 60s and 70s, there was a new concept called restriction. We knew that lower gastric volume may lead to some early satiety, smaller meal consumption. And so these two concepts, malabsorption and restriction, kind of permeated through a lot of our literature, a lot of the things that we talked to patients, and that was kind of our basic understanding about how patients lost weight after bariatric surgery. However, in what I like to call the phase 2 of this discovery process about how our surgeries worked, we had some of these great minds in surgery start to look at the actual biochemistry and physiology about how the operations actually affected our basic understanding. And the first one of the shots across the bow came in the 80s, and this was the discovery of GLP-1. GLP-1 is a 30 amino acid protein, and it was discovered in 1987. And basically what it does is an incretin, and so it increases beta cell mass, it promotes early satiety, it decreases gastric emptying, and it basically promotes insulin secretion. And we know that that when food and metabolites reach the hindgut, you have an increase in GLP-1. And Ed Mason, one of the pioneers in bariatric surgery, the godfather of bariatric surgery, did a lot of experiments and hypothesizing in the 80s about how the hindgut was the primary motivator of weight loss after bariatric surgery. Francisco Rubino and his team and a lot of others also hypothesized something called the foregut hypothesis. And in some of their experiments where they used Goto Kakizaki rats, you can see here my friend right here, the Goto Kakizaki rat, what they did was they did little gastric bypasses, and then they would take feeding tubes and they would poke holes in these feeding tubes, and if food touched the cells of the duodenum, it would have effects on whether or not these rats would develop type 2 diabetes or if they'd have their type 2 diabetes cured. And so their hypothesis was not only was there things in the hindgut, but there were also potentially some mediators in the duodenum and the foregut as well that also had an impact on weight loss and the reduction of comorbidities like type 2 diabetes. And we can see that today. There have been some experiments with duodenal sleeves, covering the duodenum, some shunting of bile acid salts away from the duodenum that can alter type 2 diabetes. And we also know that patients with gastric fistulas that have had gastric bypass, whose diabetes has been in remission, people with gastric fistulas, their diabetes can potentially come back. So there are some mediators in the foregut as well. We also know that, this concept of energy homeostasis is a complex system depending on food sensory inputs, neurostimulation of the vagal nerves, modulation of neurotransmitters, endohormones, and all these things are kind of integrated in the hypothalamus to regulate our behaviors. And we would like to kind of simplify it just like the old hypothalamic pituitary adrenocortical axis is simplified. And so you remember these pictures from your old physiology textbooks. We would like to have some kind of simple diagram for weight loss and energy metabolism that kind of mirrors this simple biofeedback pattern where you have negative inputs and positive inputs that come back. And so we're trying to work on this neurohormonal axis of energy metabolism where you have GLP-1, peptide YY, ghrelin and leptin, GIP, and that all kind of gets identified and processed in your hypothalamus with these neurons that can affect your energy-related thermostat. So now we're in this phase 3, what I like to say the age of multi-axis signaling. And we're going to talk about each one of these because they all have an impact on our understanding of how patients lose weight and how their metabolism changes and their comorbidities change after bariatric surgery. You have gut changes, your microbiota changes, you have different changes in your signaling molecules, you have neuronal inputs that change, there are effects on your bile acid, and you have this concept of endoplasticity. So in a nutshell, this little picture here, basically once you have a surgically altered tract, that's going to change the way that your gut is reprogrammed, and it's also going to affect your hormones, which can affect other organs, and those other organs and those hormones will affect your central nervous system, and this will affect your behavior, and then you have this eventual cycle, and this all changes your metabolism and your behavior, and that leads to weight loss and diabetes resolution. So as far as the changes within the gut are concerned, when patients have gastric bypasses and sleeves, you have gut hypertrophy and L cell hyperplasia. And remember, these are the cells that produce GLP-1. Remember, the GLP-1 is kind of like the magic bullet. And so we found that these cells will actually increase in size, increase in number, and produce more GLP-1 after bariatric surgery. Also, these cells, they're metabolic, they have changes as well. You have more mRNA transcription for some of the metabolites that program for GLP-1. You also have dramatic changes in the microbiome, and this is a kind of a chart that kind of shows what happens. So as you change the flow of nutrients in your digestive tract, that also changes the types and scale of the microbiota in your small intestine. And certain microflora will affect how bile acids are processed in your small bowel. And those bile acids will actually have a dramatic input on the cells of your terminal ileum and can affect the amount of GLP-1 that is produced. And so gut microbiota actually have a dramatic impact on the amount and scope of some of the end effector endohormones that are produced in your terminal ileum. So we've already kind of discussed that you have changes in hormonal communication, but you also have changes in the way that those endohormones interact with not only in your circulation, but they can also affect your nerves as well. So GLP-1 not only goes to your brain, but it also goes to your vagus nerve, and your vagus nerve then goes directly to your brain. So the way your neurons also are processed will also change as well. You also have direct changes in your brain as well. Your brain is a plastic organ as well, and so you'll have different connections that will change in your brain, and this all alters the homeostatic energy balance. And as far as what are these candidates, obviously GLP-1, GIP, peptide YY, bile acids play a dramatic role in that. And if you could look at this handy-dandy chart, remember we wanted to have this real easy-to-read chart. And so I'll kind of break it down as best I can. You have surgery, and that is going to affect two major areas, GLP-1 and bile acids in your terminal ileum, and that will go up to your brain, and that will interact with your thermostat, and that will lead to some cognitive changes with reducing hunger and giving you satiety. Interesting enough, in my studies, what I found is that we always talk about ghrelin as being kind of a real powerful anti-appetite hormone, but ghrelin has been found to play less of a role than we've thought it would do. Also, bile acids, once again, play a big role. You can see the bile acids here will increase some of the factors in the cells that will increase GLP-1. And then there's this concept of what we call enteroplasticity. So the intestine is constantly changing, and whenever you have bariatric surgery, you change and alter the cells, the structures of what they do in the terminal ileum. So you can have changes in not only the content and the number of the cells, also the nerve fibers that attach to the cells and exactly what the cells do. And so in conclusion, future directions for the science of this, if you alter metabolic pathways, we know what they do, that leads to different pharmacological targets that we can go after, new endosurgical and surgical targets for intervention. And if we have a better understanding of current procedures, it can expand our indications for surgery and lead to more appropriate patient selections for relevant procedures. Okay. Thank you very much.